And it's exciting to be able to talk to you today about, but what are we going to do each day for our patients to help them recover their lives for months and years to come for the rest of their lives? And so every day, from the day of their admission all the way to when they leave, we have to be thinking about how we're going to improve their outcomes for the rest of their lives. Because ultimately what our patients want is to be survivors, right? They want to be people who go home and live the life that they came to us to return to them. And we are the people, you are the people that are going to give them back their lives. And clearly we want to create survivors of our patients and not victims of our patients, because just because we saved the life doesn't mean our care was successful, right? So many patients, they may live, but they go off to rehabilitation or to nursing homes, where often they never leave, they never walk, they never go back to a life that's worth living. Because ultimately what our patients want is to be able to walk down the street, whoops, let me go back, with the patient, with their family members and hold their grandchildren again. That's what our patients want from us, and that's what we need to give back to them. And so I ask my residents and my trainees every day on rounds, are we creating survivors of our patients, or are we creating victims? And we always need to be thinking about how we're going to give back the life to our patients they came to us for. Because the reality is, a patient in the ICU, even on a ventilator but a few days, 60 to 80% of those patients will have significant physical and cognitive defects and limitations that can go on for years to come, and sometimes for a lifetime. And so this is truly an epidemic, and our COVID survivors are suffering long COVID. That can make it worse. And so how can we win this quality of life war? How can we give back a meaningful quality of life to our patients? Because the reason they're losing it is a critically ill patient can lose 1 kilogram of lean body mass a day. It's a lot, and it happens even after major surgery. And that's because we as humans are not evolved to survive critical illness. The patient will remain catabolic and hypermetabolic for years after their illness. We know a burned child will remain catabolic for 2 years after they leave the hospital. And so how many of you, especially the dietitians in the room, have fed a patient 40 kcals per kilo and watched them lose weight, right? And this is why we need to start early. We need to do things that deliver the protein we need, and we need to use anabolic agents perhaps in rehab to ensure they're using the calories. And so I think that's critical. And so to do this and to give patients back their lives, we have to be better than we are now. We have to overcome the challenges that we face. And to do that, we need a combination of therapeutic nutrition, we need good rehab, we need good physical therapy that takes into account how an Olympic or professional athlete trains. And in my next lecture, I'll talk about how we prescribe exercise, just like we need to be prescribing nutrition. So it's challenging though. Our patients have many challenges that make it difficult to feed them, right? They're sicker than ever. They have many limitations and challenges. And so how do we give nutrition in these sickest patients? Well, what are we actually feeding now? What do we feed our patients now? This is surveyed every 2 years by a group in Canada, and perhaps some of you have participated. And we know that for the first 2 weeks of ICU stay, we deliver half the calories our dietitians write for our patients to receive. This would be like us writing for a gram of vancomycin as an antibiotic and the nurse delivering 500 milligrams for 2 weeks. We'd get fired. Why is it okay when we don't deliver the nutrition our patients need? Again, this isn't for a day or two they're getting half their needs. This is for weeks they're getting half their needs. And protein delivery is even more challenging. Our patients are averaging 0.6 grams per kilo per day of protein, not for a few days, for a few weeks. So it's no wonder they're losing 1 kilogram of lean body mass a day. It's devastating. So we need to be better, and how can we do that? So I think the first thing we need to realize, one size nutrition does not fit all, and we need to be personalizing nutrition delivery, giving the right nutrient in the right patient at the right time. To do that, we have to measure. We can't use predictive equations anymore. And so what do our guidelines say about what the latest data tells us for delivering nutrition in our critically ill patients? And so to talk about that, I'm going to tell you about a patient I took care of not so long ago. And his name was Elijah. He was a professor at the university I work at, and he and his wife both had influenza. Unfortunately, he got quite sick with his influenza, was admitted to the hospital. He started off on low oxygen, but quickly deteriorated and needed to be intubated, placed on the ventilator. He was very hypoxic, ultimately with a very poor P/F ratio, and he needed to be paralyzed because he was so hypoxic and his lung injury was so severe. And then ultimately, of course, now we know in a patient acute lung injury, we prone patients, correct? How many of you prone your patients? Who does proning? Raise your hands. Raise hands, raise hands. I hope all of you are proning your sickest patients when they're in ARDS. So these are his vital signs on that first day. And so his vital signs are reasonably normal. His lactate is normalized. His mixed venous is normal. So this is a patient who's now stable, but still very sick on vasopressors. And so I was asked to write a paper with experts in nutrition from around the world about how best to feed our patients. And these are our recommendations. There's also the new FASPEN guidelines that have just been updated. That's something all of you should read. And then the FCCM guidelines. And I'm going to use these to talk about how best to feed our patients and how to optimize our care. So still, we suggest starting nutrition, of course, right away, within 24 to 36 hours. Feed the stomach, not the small bowel. So again, most of the world feeds the stomach. There's no benefit to small bowel feeding or post-bowel feeding. And we now say, of course, that enteral nutrition, although is our first choice, enteral and parenteral nutrition are equally safe. And they can be used interchangeably and started at any time. They carry the same benefits and the same risks. So they're the same thing, so you should start parenteral nutrition much sooner if you're not successful at getting to goal enteral nutrition. And so again, you want to start with slow, gradual feeding. You want to increase your protein and your calories slowly, and we'll talk about why that is. And so what about this particular sick patient? How best to feed him? So we'll talk about the different challenges our patients face, and particularly this patient. So what about feeding on vasopressors? This patient's on norepinephrine, and so can we feed this patient? And right before COVID started, the editor-in-chief of Critical Care Medicine, big ICU journal, asked me to review the literature on feeding on vasopressors. I hadn't read it myself for a while. And not only to discover it's safe to feed on vasopressors, but it saves lives. And there's a large study that shows this and says we should definitely be feeding on vasopressors. And so this was a study done in Japan, 52,000 patients studied that received Levophed or another vasopressor, and they looked at if they were fed within 2 days of their illness in the ICU or after 2 days receiving enteral nutrition. And what they found was mortality was considerably lower in the patients who received early enteral nutrition on vasopressor doses up to 0.1 mics per kilo per minute and up to 0.3 mics per kilo per minute, which seems like a lot, but this data was very strong. It says we should be even feeding these patients, and usually trophically, I would say, but we should be feeding them early because it saves life. And even at 0.5, there was no greater risk to the patient. So even at these very high doses, it seemed to be safe, although beneficial at 0.3 and below. So the results show that this is a safe and life-saving intervention. You should be feeding your patients. And why is that? So this is where the non-nutritional benefits of nutrition occur, right? So just feeding even trophic feeds, 10 or 15 cc's an hour, protects the gut microbiome. So that's a benefit that is not related to the nutrition itself. It reduces intestinal permeability, so it's less likely to cause infection. It reduces the toxicity of the lymph. So your lymph drains out of your intestine and it goes first to your lung circulation. And so if you ligate the lymph duct of an animal that's in shock, they won't get acute respiratory distress syndrome. They won't get lung injury. If you don't ligate that, they do get lung injury. And then just putting protein or fat into the stomach in small amounts signals the vagus nerve to be anti-inflammatory for the whole body. So even small amounts of nutrition can have great benefit. In fact, just getting 20% of goal prevents the breakdown of the microbiome, protects the gut barrier, and improves immunity and vagus nerve signaling. So even a small amount matters. And then you can give the rest by PN. So how to do this right? And I talk about this in the paper. This is a table. First, you have to be sure they're resuscitated. Don't feed EN or PN to patients that are in shock and that are unstable. Don't do it. So the lactate should be normal. The mixed venous should be normal. The vasopressor dose should be stable or coming down. Doses of 0.1 to 0.3 are safe as long as the patients are resuscitated of Levophed, and different drugs have different risks. Levophed is the safest. It preserves gut blood flow the best. Vasopressin and dopamine are the worst on the gut, and so they are much higher risk of causing gut ischemia if you're feeding on them. And then start slowly. And these are patients I would check residuals in. I would not encourage you to check residuals on other patients, but these patients you should. You need a monitor of the gut perfusion. So if they get distended, have residuals above 500, you need to stop. And so again, feed the stomach, never feed the small bowel in a patient on pressors, because you don't have a monitor to guide you if they're in stress or if the gut is not receiving oxygen. And then residuals are key. So what about the patient's paralyzed? Believe it or not, I still get questions from doctors who say, oh, the patient's paralyzed, we can't feed them because the gut doesn't work, it's paralyzed. Yeah, that's crazy. The gut, of course, is smooth muscle, paralytics don't affect it, but I get these questions all the time. This same group in Japan that did the vasopressor study showed that feeding paralyzed patients not only is safe, but saves lives. And they did the same kind of study, a large database study of patients on paralysis, looking at patients who were fed in 2 days or after 2 days. And what they found was significant improvements in mortality and significant shorter lengths of stay in patients on paralysis that were fed early. So your paralyzed patients need to be fed, that's critical. So again, it saves lives to feed these patients. What about prone patients? Can you feed a prone patient? You definitely can. And the guidelines even say it's safe, and there are studies that show this. We feed all our prone patients. We always tip them up a little bit to keep anything that might aspirate from coming up. But you can definitely do this and elevate the head of the bed a small amount, but definitely feed your prone patients. So then how much to feed? This is critical, and we'll talk about this in the next lecture as well a little bit more. So again, how much should we be feeding our critically ill patients? And so again, you have to start slowly. You don't ever want to start someone at full feeds. You want to ramp up your calories and protein slowly. And so I think that's a critical message. And why is that? So we know our bodies have the same response to stress, whether a tiger bites us, the surgeon hits us, or a car hits us. We break down muscle to generate amino acids, to generate glucose, to run away from the tiger or run away from the surgeon. And so that's critical. That's how we provide our non-protein calories. So we don't need as much glucose calories early, but we do need our protein, of course. And this is a really critical graph. This is stored in every ICU lecture in the world now. This is the amount of feeding, the percent of measured indirect calorimetry feeding that we should be giving our patients to save lives. And it's 70 to 80% of indirect calorimetry measured feeding. How many of you have indirect calorimeters? Raise your hand. Ooh, very few. We need to change that. So that's critical, right? All this data is based on having accurate measures. But again, you don't want to underfeed, that's dead, and you don't want to overfeed. And that's why it's so critical to know the right number. And so these are what the FASPEN guidelines say, right? So you want to start early, slow, trophic nutrition and build it up. And then you don't want to go above 70% of measured for the first few days. And then after 3 days, you can go to goal. So this is what our FASPEN guidelines say. I think these are excellent recommendations. So, but then how much, right? We need to be measuring if we're going to be accurate. This is the new era that we need to be practicing, all of us all over the world. And all our guidelines say we need to be using indirect calorimetry. Now, the data is very strong for this. That's why these recommendations exist. Using indirect calorimetry to guide feeding reduces mortality. This is how you justify it to your hospitals and why you all need one and why they need to buy you one. There's 3 meta-analyses, not one, there's 3 of these that show this benefit on mortality. So this is now really good, strong data. The challenge has been, up till now, the devices haven't been very accurate. They've been hard to calibrate and use. You need a respiratory therapist. They're expensive. And there was a lot of patients you couldn't use them in. Well, that changed. So FASPEN funded a grant to a number of us around the world to build a better metabolic cart with Cosmed. And so about a few years ago, we designed a metabolic cart that our dietitians now run. We don't need physicians to do it. We validated it in this study. We were one of the sites in the US, and there were other studies and sites in Europe. And this device now is supposed to overcome, the goal is to overcome all of these challenges. Oops, hold on a second. Hey Eli, hand me that remote. So this is the challenges we're trying to overcome. I think this one just jammed. There we go. I'm going backwards now. Hold on a second. This remote just had a little error. So we built a new metabolic cart, and in the US now, our dietitians are running that cart. And I think that's what our ultimate goal is. Let me go forward a little bit. So again, it reduces mortality, and we had to overcome these challenges, and we validated this. And these are the new benefits of the new metabolic cart. Again, instead of taking 60 minutes to set up and having a respiratory therapist do it, our dietitians do it in 5 minutes. And it calibrates itself. It's small and portable, it's easy to use, it's highly accurate, calibrated by mass spec. You can use it in intubated or non-intubated patients. And it's, here, I'll leave that up if you want to take a picture of it. And you can use it in FiO2s up to 70%. You can use it on CRRT. There's many, many patients you can use it on accurately. And so it's a major advance. And this was the idea that this is something a dietitian or a physician or anyone could use. And it was very quick. You can make these measurements in 10 minutes. So again, if you want to read more about it, these are some of the recent papers we've published on the new metabolic cart and why everyone should have some. So again, feel free, and I'm happy to send you these if you want to email me. And again, this is how we should use it. So we need to make multiple measurements, right? You can't just take one. The patients change if they have surgery, if they get septic. The patients need to be measured twice a week in the ICU at least, and once a week on the floor. And then after they're getting better and they're doing rehab, you need to give them like 1.3 times their resting energy expenditure. Again, when I was recovering from surgery in ICU, I was getting 4,000 calories, even though my resting energy expenditure was 3,000 calories. So you have to allow them to have enough calories and protein to gain weight and muscle. So again, protein is critical as well, and this needs to be the complete package. And you can't build a house without bricks, and you can't build muscle without protein. And so this is fundamental. So what are our protein requirements? I think a key thing to think about is in older patients, they become anabolically resistant. It takes more grams of protein to make the same amount of muscle when we're older than it did when we're younger. And many of our patients are older. Now, not everyone who gets older loses muscle. You don't have to lose muscle mass as you age, but it takes more than just eating right to look like this. But we can learn a lot from athletes. So again, how many of you bolus feed your patients in the ICU? Who bolus feeds? You should do it more. We bolus feed about half our patients. It's much more physiologic. The body works to build muscle best when it goes from low protein amounts in the bloodstream to high protein amounts and then back and forth. Otherwise, bodybuilders will all have feeding tubes. It doesn't work to be continuously fed to build muscle. And taking in protein at night before patients go to bed, an oral nutrition supplement. That's when we're anabolic and we release growth hormone is overnight. And then of course exercise is critical as well. Because our critically ill patients are the most anabolically resistant. And that's where things like HMB, oxandrolone and testosterone and other interventions are really critical. And even just getting 30 grams a day of protein extra a day is going to save lives. And this was in thousands of patients studied. So even small amounts of getting more protein in is beneficial to your patients. And again, remember that U-shaped curve for calories? This is the protein curve. And mortality continues to go down as protein amount goes up. And that's why getting protein is so critical. Now, should we ramp up protein like we do calories? Should we start low and build up? The answer is yes. And this is a critical trial that was done by Arthur Van Zanten, where he looked at the effects of different doses of protein on different days in the ICU, and this is what he found. He found that if you got more than 1.2 grams per kilo per day of protein on the first 2 days of ICU, your mortality was actually higher than if you got 0.8. So you need to be ramping up, and then that curve reversed. And the patients that got more protein, more than 1.2, had lower mortality. So again, to make this easier, I want you to look at this curve. So the patients in the blue are patients that got low protein for their whole stay. They do the worst, we know that. The next curve is the patients who got greater than 0.8 grams per kilo or higher protein for their whole stay. They do a little better, but the patients who do the best are the patients who get 0.8 grams per kilo for the first few days and above 1.2 after 3 days. So you want to ramp your protein up. So again, you want to ramp protein up and calories up the same way. And again, I encourage you to take pictures of these slides and share them on social media so your colleagues who are outside can see them as well, because the room isn't very big, and so please feel free to share these. So again, back to our patient. So he's on trophic feeds, but we can't get them up. He keeps having residuals. He's very sick, and so he's only getting 25% of his protein and calorie needs. And so what, of course, do we do? Well, we need to start PN, because our patients, as we saw before, are almost never getting goal. And so supplemental parenteral nutrition is critical because getting to goal in is difficult. How many of you use supplemental parenteral nutrition? Raise your hands. Ooh, not very many. More of you. Yeah, I want to see more hands. That's what I want. Good. So we need to be supplementing with early supplemental parenteral nutrition sooner. And the key message you can share with your physicians, because they don't know it, is TPN has no association, zero association with infection risk. Large studies, thousands of patients in journals you've heard of, New England Journal, Lancet, and JAMA, showed there's just as safe to put TPN through a central line as saline through a central line. So if you give the patient saline, you should give the patients TPN. And you shouldn't be stopping it if they get bacteremia. Again, you don't stop the saline when you get bacteremia, you shouldn't be stopping the TPN either. And so I think that's critical. And our guidelines finally say that. There's no difference between EN and PN. You should use them interchangeably. If you're not at goal EN within 3 days, 2 days, you should be feeding. And in fact, the data says you can reduce mortality in a large study in JAMA surgery by giving early supplemental pronutrition. This was a study of many patients who got early supplemental pronutrition versus not getting it till day 8. The patients who got early PN had less infections. So TPN reduces infections in modern practice, and I think that's critical. So the last topic I want to cover with you is something that happened to Elijah. He got renal failure, and he got put on CRRT. And about a week later, he developed severe pancytopenia. His white count fell dangerously low. He was dying of pancytopenia. We ruled out all the drug-related causes. What nutrient issue might be causing his pancytopenia that CRRT causes? Anyone know? It's copper deficiency. Virtually every patient you put on CRRT will be copper deficient by day 5. So if you use continuous dialysis, your patients are getting this life-threatening complication. He had this. 90% of patients get this. In fact, all the trace elements and water-soluble vitamins will become deficient on CRRT. And the only one that doesn't become deficient is zinc because it contaminates the fluid that the CRRT uses. But B6, selenium, copper especially, and again, we lose amino acids as well. So you'd be feeding 2.5 grams per kilo per day to patients on CRRT to make up for the loss. You lose 30% of your amino acids to the circuit. But severe consequences are happening to our patients that we probably aren't seeing. Pancytopenia and neutropenia can cause from low copper. I've seen patients that look like they've had a stroke. They won't wake up. You do CT scans, they're normal. You give them a little bit of vitamin B6 because their level is 0. Vitamin B6 levels of 0 are common on CRT. It can cause severe encephalopathy and obtundation. And so you give a little 50 milligrams of B6 back, they wake right up. If you go copper deficient for more than a few weeks, you get permanent neurologic deficits. You get weak and it never goes away. So you can't let your patients be copper deficient. This weakness, some of the ICU-acquired weakness that lasts a lifetime, is probably copper deficiency. This happens in obese patients who have gastric bypass and don't take their supplements. It happens in ICU patients as well. And then lactic acidosis can occur as well. So these are critical things. You need to be supplementing. We give copper gluconate to all our CRT patients at 2 milligrams. We double dose their trace and micronutrients and their TPN. We always give them multivitamin, and we give carnitine IV because carnitine gets deficient too. We did a study showing 90% of patients on CRT are deficient in at least one nutrient in 3 to 5 days. So this is happening in all of your patients. And again, copper and B6 are the most common, but selenium and carnitine are common as well. Lots of malnourished patients who aren't on CRT are deficient as well. We checked a lot of patients because we had the money to do it, and we found severe deficiencies. This is very common. And it increased mortality in some patients. In fact, any of these micronutrient deficiencies increases mortality 2.4-fold. You need to be repleting these. You need to be checking these. So this is a great paper if you want to read a paper about how to do this and how to think about these nutrients and how to replete them on CRT that you can look up or I can send to you as well. So this is a really critical paper. So last thing, as we start oral nutrition, we need to be sure that patients take in enough. We know they only will take in about 700 calories a day because the hospital food is not good. And so we use an oral nutrition supplement with H&B because there's a large randomized trial, hundreds of patients, many, many centers, showing it reduces death by half in patients who get an oral nutrition supplement with H&B. I take H&B at home, and I would encourage all of you to take it as well. It's an outstanding muscle-building supplement. But every 20 patients you give an H&B oral protein drink to, you save a life. So we send our patients home with this for at least a month. 3 months is better. And so again, we need to address all the causes of muscle and ICU dysfunction in our patients, and that's bed rest. Patients should be out of the bed during the day. The beds are evil. They cause people to die. Don't let them stay in the bed. I tell them they need to be in the chair. Testosterone replacement is critical, safe, and reduces cardiac diseases. I'll talk about in the next lecture. And we need to give enough protein and calories to our patients. These are some papers if you want to learn more about some of these multimodal techniques. I'm happy to share these as well. And so in conclusion, Again, how do we do this better? How do we create survivors and not victims? We have to make sure patients are fed personally and personalized. One size does not fit all. The way we feed patients should not be the way we've done it in the past. It should never be the same. And we have to be better to do this, right? We have to be measuring and personalizing with indirect calorimetry. And if you can't measure it, you can't improve it. And so again, these are all the different new techniques. I'll talk about in the next lecture some of these as well, but we have a lot of new opportunities, a lot of new devices that we should start to use as standard of care, including the metabolic cart. These, again, we can feed on vasopressors, we can feed paralyzed patients, we can feed prone patients, and we need to use indirect calorimetry to improve our patients' outcomes. And this paper covers that if you want to learn more about all these topics from this lecture. So in the end, start your feeding slow, ramp up your calories and protein, make sure that you're increasing that as patients get more active, and consider anabolic agents in their recovery phase. And this is how you use the metabolic cart. This is a critical part of our care now. So again, we need to take responsibility every day, not just for today's patient issues, but for the lifetime of our patients' needs. And if we do that, we can take patients who look like this, have them walking on their ventilators like this, and then have them go home like this, or at least like this. And that ultimately is what we want. Again, I encourage you to follow on Instagram and share this new knowledge on Instagram. My lectures are on YouTube. If you want to watch the whole lectures, subscribe there. And I'm happy to send papers or these slides by email to anyone who'd like to ask for them. Thanks very much.